Hi everyone, and welcome back to the HP Leader YouTube channel. And you are watching a day-to-day dedicated to cardiorespiratory rehabilitation, particularly during the COVID-19 pandemic. So our next session is on oxygen assessments, and it's also on psychology. So I am not going to take any more of Mel's time. I'm going to let her share her screen and introduce herself. So over to you, Mel. Any questions in the chat box? Don't forget, in the HP Leader chat box, or DM me on Twitter. Thank you.
Okay, can we see the correct screen?
Yep. Oh, nope. It's just went onto your. There you go.
Okay, bear with me.
Perfect.
Thank you. Hello everyone, my name's Melanie Palmer. I'm a physiotherapist and I work in Harefield Hospital near London. And I've been asked to speak to you today about our home oxygen service in Hillingdon and some of the challenges that we've faced during COVID-19. So this will be very much about our experiences, and I would welcome anybody else to share their experiences in different home oxygen services across the UK. So please feel free to ask questions via Rachel. So for those of you that don't know, as I say, I work in Hillingdon, which is a small borough on the northwest side of Greater London. We are commissioned on a local basis by our CCG, and we as a service are asked to provide oxygen assessment and review for all patients on oxygen in the local area. The primary sort of focus of our assessments is for long-term oxygen and ambulatory oxygen therapy. We are a multidisciplinary team. We are predominantly physios, but we do have nurses working in the service depending on who's in post. And we are consultant-led. So that means each week we have an MDT with our respiratory consultant where we can discuss difficult patients and get sort of multidisciplinary input and advice. Perhaps more unusually, we, prior to COVID, were primarily based in the hospital. So that means that we would ask the patients to come to us to have their LTOT and ABOT assessments, as opposed to going out and seeing people in the community. With our demographic, we found that worked quite well prior to coronavirus. Patients were quite happy to come, and it meant that we could use our time really efficiently to see as many patients as possible within the time that we had. However, everything changed earlier this year. And as of lockdown in March, our activity was very limited and changed an awful lot. So initially, all of our staff were redeployed to assist with the inpatient physiotherapy team. And so there was no activity within the home oxygen service for about 3 months. Once we came back into the service, our focus really changed to trying to create some sort of service that was accessible for patients within the new constraints that coronavirus brought. And we experienced, I'm sure, the same challenges that have been spoken about by previous speakers. We changed our practice a lot initially. So we were trying to conduct our assessments via the telephone and using video clinics. So we have a system called Attend Anywhere, which means we could sort of do some sort of face-to-face a chat with patients. We obviously were able to complete some sort of risk assessment and a review essentially on the phone for those patients that were already established on oxygen therapy. And on the most part, that went better than I expected. Patients were able to articulate how well they were getting on with their equipment, modalities. We were able to talk through sort of safe use of oxygen at home and appropriate use of oxygen at home. But obviously there were the obvious limitations in that we weren't actually being able to see how patients were using their equipment. If we felt it was necessary, we were able to post equipment to patients. So we were sending pulse oximeters in the post, phoning up the patients, asking them to tell us their saturations at rest and during exercise. And of course, there were those urgent patients that were coming up, perhaps those patients where there were safety concerns, who were very unwell in the community, who it was felt that oxygen assessment was more urgent. And we were trying to see those patients on a case-by-case basis. But in those initial stages, it meant that there was lots of discussion, quite rightly, that needed to happen with our management and our infection control teams to make sure that we would do that safely. So in terms of our oxygen service, being that we were based in the hospital, we suddenly had a situation where there was no space for us to assess our patients anymore. With social distancing and with the new infection control procedures that were in place, all the services were trying to restore and reactivate their caseloads, and it meant that space was a real premium within the hospital. Combined with the fact that obviously patients needing oxygen therapy are very vulnerable and significantly vulnerable to getting coronavirus and being being affected more severely by the disease. We also had issues with staffing. So obviously our staff, as I said, were initially redeployed, but we've had the same issues as everybody else, with some staff needing to shield or self-isolate due to contact with COVID, or being symptomatic and then having to wait for tests. And we had a big problem in the fact that because we didn't exist in the community before coronavirus, we didn't have all the bits of equipment and things in place that would be required for us to move ourselves straight away to being a community-based service. So as an oxygen service, we don't have a portable blood gas analyzer. We would have used the ones based in hospital, and that sort of became a real problem in trying to change the way in which we saw these patients. As has been spoken about many times today, we are weighing up the benefits versus the risks of seeing these patients. So particularly for long-term oxygen therapy, we know there's a survival benefit associated with the appropriate prescription of LTOP in patients with chronic respiratory disease. And of course, with oxygen, we need to make sure that oxygen is provided in a safe, timely way that's backed up by evidence. And we also want to make sure that that oxygen is being used appropriately. So we have many patients in the community who might not be meeting the required amount of hours, or perhaps haven't been given the right equipment, so they're not able to use the equipment in the way that's the most effective for them to use their treatment. But on the other side of that, we have the risk of transmission of coronavirus to vulnerable patient groups, and as a service, we couldn't be placing our patients at greater risk of transmitting COVID. So when we're looking at our our response to coronavirus, obviously, like other services, looking at restoring their activity, we needed to complete risk assessments and safe risk assessments with our MDT colleagues to try and restore LTOT activity in the hospital, and that was for us seen as one of the priority services to restore. So we wanted to make sure that we were seeing all patients that had been referred for LTOT that didn't have it at home. They were sort of our initial patient group to try and see. And we decided that probably the safest way for us to try and see patients was on a green pathway, which meant that every patient that attended that green clinical area had been screened for coronavirus prior to coming in. We would try and minimize our contact with the patients by completing the subjective assessment over the telephone, which would make sure that us seeing them face to face was really warranted and was the most appropriate thing for that patient at that given time. We also wanted to make sure the patient felt happy and comfortable with the processes in which we were offering. For all other services, we needed to try and maintain social distancing where possible during the appointment. Obviously wearing the appropriate PPE for a green area, and spacing our patients to allow adequate time between each person for cleaning. I've put up there our risk assessments, but on the next slide I've enlarged some of the areas which are more important. So as I've said before, we want to minimize the risk of transmission of coronavirus to our patients. And one of the risks of in this green area was that what we would do is test the patient for coronavirus, ask them to self-isolate in that 72-hour period prior to their appointment. But we had no guarantee that the patient would be able to do that or would sort of adhere to the requests that we were asking. We had a small risk that our swab result for the patient would be inaccurate, or they would develop symptoms of coronavirus after coming in. And we have a small risk that members of staff may be infected with coronavirus, and that would place the patients at risk. So what I've done on the right is just sort of highlighted in more detail some of the control measures that we put in place. And I spoke about those briefly before, but I thought it might be useful to see these in more detail. These risk assessments were produced in conjunction with members of the MDT, our managers, and our infection control team, who have been amazing throughout in trying to help us complete our activity in as safe a way as possible. Then we have the fact that, as I said before, our patients are really high risk of COVID-19. One of the big risks for us was that we would have preferred to have seen these patients in a side room, but we just didn't have side rooms available in the hospital in the area that we were seeing patients. So we tried to mitigate that risk as much as possible by all of the other measures that we've put on the other slide, and still continuing to explore other ways in which we can see patients for their assessments. One of the big problems we've found is that not all the patients that we see are able to access our green pathway, and that might be because they are not actually able to attend the hospital in the first place, particularly for those patients that are living in care facilities. They're not able to self-isolate, perhaps because of care needs that they have at home, having visiting people coming in to support them in the community, or as a large proportion of our patients have expressed they're not able, or they're not willing to come to the hospital during a pandemic for an assessment. Even if they haven't been told to, they are wanting to shield at home and try and keep themselves as safe as possible. So we then took to working towards developing these amber pathways for patients to be seen in hospital and in their home, and trying to open up our service to ensure that all patients are able to access assessment for oxygen in a way that they feel comfortable with, in a way that's as safe as possible. So again, I've put up here just for information the risk assessments that we've completed for seeing patients in an amber environment. What I thought would be interesting as well is when we're thinking about home oxygen therapy, and we've sort of just talked briefly about just trying to restore a basic oxygen service. With coronavirus, we were very aware that there might be increased demand on oxygen services. And I don't have data for that across the UK, but I do have some data of oxygen prescriptions that were completed in London. So between the 1st of March and the 30th of July, there were just under 200 referrals for home oxygen, which were coded COVID-19. So that meant that it was directly related to the fact that that patient had COVID-19. However, that was still quite a small proportion of the overall referrals that were coming in for London. So it only made up 13% of the total volume of referrals for oxygen that were coming in. So all of the other patients with interstitial lung disease, COPD, obstructive lung conditions were still making up the main bulk of the oxygen users in London. Most of those referrals that came in were urgent referrals, which indicates that they probably were to support hospital discharge. So they were for 4-hour prescriptions, where from the submission of the HUFA prescription, the oxygen company would install the oxygen in that patient's home within a 4-hour period. And the majority of those prescribers were GP and community nurses prescribing on a HUFA assessment form. One of the big reasons why we're so worried about restoring our home oxygen service is obviously the safety implications of using oxygen at home, and the potential problems that may occur. So when our service was closed and we weren't routinely seeing patients, one of the big worries we had was that there would be unsafe events occurring, and there were ways in which we could monitor that through the data that the oxygen companies were were providing us the communication coming back from Air Liquide to us if any adverse events were being reported. But managing oxygen safely in the home and managing those individual cases where perhaps oxygen isn't being used as safely can take up an awful lot of clinicians' time, but is obviously of utmost importance. And we know that when we're thinking about prescribing oxygen therapy at home, there's lots of different factors that are in play when considering risk and the risk of that person using oxygen. So the big one up there at the top is smoking, and smoking and oxygen therapy is obviously a big no-no, but where we can be quite stringent about not prescribing oxygen to patients with oxygen who smoke, who require oxygen therapy. It's more difficult and a little bit more grey if those patients go back to smoking while perhaps they've already got the oxygen at home. And that involves a lot of MDT inputs and discussing things on a case-by-case basis to ensure that that person and the people around them are safe. Other factors that might affect negatively risk when considering oxygen prescription is misuse of drug or alcohol, mental health disorders, cognitive sensory impairments, reduced mobility, those people that live at home and social deprivation. So obviously none of these factors on their own are going to stop an oxygen service providing oxygen therapy for a person, but it may mean that there's additional services we need to link up with, or more holistic management that needs to go on to ensure that oxygen therapy could and would be used safely in the home. One of the big risks of oxygen therapy obviously is the risk of fire, and that's not only that person may sustain significant injury due to smoking at home or fire at home with a combustible gas, but it might be that they cause harm to other people they live with or other people in sort of adjoining houses. So within, we live in quite a densely populated area, and 85% of those dwellings are connected with another house, either by being a semi, a terrace, or a flat. So if, in the worst case scenario, there was a house fire with somebody that had oxygen therapy, the impact of that might not only affect one household, it might affect multiple households. And so we have to consider, as well as the benefit of giving any individual person oxygen therapy, the risk posed to the public secondary to that person having oxygen therapy, and just ensuring and supporting them and using it safely. So as I've sort of mentioned throughout the presentation, the risk assessment of oxygen therapy and those patients who have existing oxygen therapy at home was really important to us during the pandemic. We, as best we can, completed those IHORNs on the telephone, linking up with our colleagues in the community, so the fire service, social services, our community care colleagues, palliative care, trying to get as much information as we can about those people. We monitored the data provided from Air Liquide. So obviously their technicians were still going out to see people during the pandemic, and they would have a look around the property and complete their own risk assessments as they went out. Finally, I've just included here some resources that have been produced by, so the first was produced by the London Respiratory Network. So oxygen therapy outside acute settings during COVID-19. So oxygen therapy in the community. They've produced some really lovely resources that are full of information. So thank you to them. And the ARTP also produced some guidance about oxygen assessment during the coronavirus earlier in the year. So I've included that there as well. The whistle stop tool. So please feel free to ask any questions you may have. Oh, apologies, I did have a summary slide. I think in summary for us, the pandemic, it's been awful. I hope we can use it to make really positive changes for the future. I would love us to have a really flexible service with lots of different pathways that fully is able to meet patients' need. And I feel that it's also pushed us to work more closely with our community colleagues in the borough, and that's only been advantageous for our patients. a final message to leave you on. As you know, sort of safe and accurate prescription of oxygen is key. Oxygen therapy is for management of hypoxemia, not breathlessness. So I know as physios we're always promoting that, but that's a really important message. Even during the pandemic, we want to support safe and accurate of oxygen therapy alongside the BTS guidelines, and with full management of risk. So whether that's a staff member completing a prescription on a hoof A or hoof B, in signing that prescription form, we're still accepting responsibility for completing a risk assessment for that patient, and really thinking through how that patient will manage oxygen at home, and making sure then that the referral goes forth to the relevant home oxygen service to manage them at home. Thank you.
Thank you so much. Thanks, Mel. So that was such a comprehensive review, and I know a very personal reflection on your own service, which actually, like I mentioned at the very beginning, that's all we can do, can't we? And as centres, there's very much collaboration going on, comparison. What are you doing? What are you doing? How are you keeping things safe? But the development of individual or specific service level alterations to allow assessments, allow the interventions of oxygen therapy to be delivered safely, has been something that obviously had quite a bit of national variance depending on how services are set up. So I do appreciate your reflections and sharing your experiences for sure. Now, there is a couple of questions about what information or literature did you give to patients, especially those like using pulse oximeters at home, and did you give thresholds for saturations?
So the pulse oximeters we were using more in an assessment capacity. So we would send them out and then essentially guide that person on the telephone about how to read them. So it wasn't something we were leaving with the patient for a sustained period of time to monitor their own saturations. Although there's benefits to doing that, personally I feel oxygen saturations, as we know, are so variable, up and down all day long. I don't like to encourage patients to become too in tune with numbers, although obviously they do guide us in terms of what we may need to do. I would prefer to give patients more messages about how they feel, about recognizing their breathlessness, looking for other signs of cyanosis like blue fingers, blue lips, other ways as opposed to just numbers on a monitor.
I completely agree with that. Coming from a ventilation background and a neuromuscular background, often by the time some of our patients have reached for the SATS monitors, they know themselves and they know the intervention that they have to do, whether it be to stop, to catch their breath, whether it be to, use whatever physiotherapy technique or airway clearance device or whatever. So I'm completely with you on that. I think sometimes there's a bit of a, not fixation, but because it's and patients go out and buy these themselves, don't they? And in COVID times, that's what we've seen. I think the scary thing here is the happy hypoxemics, the patients that don't have no signs, they're dropping the saturations into, I think, but that's a very different cohort of patients that we're talking about. In terms of, you mentioned about your referral criteria, about the length of time someone's been hypoxemic, about it not just being after an acute phase, and having that safeguarding, if you like, about who should come into an long-term oxygen therapy service is really important, isn't it? And that needs to be adhered to in COVID times as well.
Yes, absolutely.
So a couple more questions. Are there also long-term plans to have permanent home oxygen service, community staff often best placed to assess home risk? So I think that's probably in reference to hospital-based oxygen services.
Yeah, we're really unusual because we are, a tertiary centre that also has its own DGH within one borough, and our service is slightly split across the two hospitals. But the integrated service that we have in the community are fantastic. They're they provide an amazing service. And I think I completely agree. It's we need to link up more with them, work more closely with them, and I would love to see a service that that operates more in the community in the future. But I think we just need to continue to listen to our patients, ask them what they want, and try and design our service to meet their needs.
Yeah, and there is a comment here about what's your view on COVID patients being given oxygen? Do they have to meet BTS criteria for that? Do you have an opinion on that?
I must admit I don't. What's your thoughts, Rachel?
So my thoughts are that if this is a hospital patient being discharged, then this is a multifactorial condition that we're seeing, and patients need to be medically stable to be discharged. And if someone's profoundly hypoxemic, they're not medically stable. So it's a clinician call at that time. And I know some centres that have, in the height of pandemics, discharge patients who have non-life-threatening hypoxemia. They might have comorbidities, they might have it might be transient drops in saturations, and there's exertional hypoxia. So it's a really hard question to answer. I think when we're in non-pandemic times, there would be clear criteria that patients have to meet to get in to be offered long-term oxygen therapy for all the right reasons. In pandemic times, obviously, things have been a bit different. I don't know patients that were being offered home oxygen therapy on the back of a COVID admission as a standard. I think they were just being followed up. Some centres were giving out oxygen saturation monitors, home oxygen saturation monitors with patients, and having thresholds if they needed to get in contact with someone being readmitted. That's my level of knowledge, if you like. Not being involved in discharge pathways.
Yeah, I agree. In our hospital, we weren't one of the surge centres or one of the hubs, so we operate very much on sort of as our HOSAR, but less for the oxygen for discharge. So it's I'm sure some of the other viewers will have more information and knowledge than I do on that factor.
And the final comments were just about you being redeployed at the height of the pandemic and how did you manage? I think there was a number of services that were shut down in the first wave, and I think that definitely won't happen again in second, third, fourth wave. So I completely agree with the comments. It's a very high risk population of patients that you serve, and very vulnerable. Yeah. So yeah. Next, whatever happened in the first wave, I think there was right reasons, but now we know what we know. I think these services will continue.
Agreed.
Well, thank you so much for your time. You've been amazing. Thanks for being on time. We are bang on time. We have got Chris who's joined us next. I just want to say a massive thank you to you, Mel, and for your input. Enjoy the rest of your Saturday.
Thank you for having me.
So I am delighted to introduce another disclaimer, a colleague of mine, Chris, who is a psychologist, and she's the most amazing psychologist specialising in all things respiratory. You have a very wide remit for your job, don't you, Chris? And this is such an important area, one that is often overlooked, in my opinion, and it's meeting the psychological needs of patients in normal times, let alone in pandemic times. But without stealing any more of Chris's time, I'm going to let her share her slides and introduce herself properly. So over to you, Chris.
Thank you. Okay, so I haven't done this for ages, so I'm going to bear with me whilst hopefully it works. Okay.
Perfect so far.
Brilliant. Oh, here you go, 1 step 2 closer. Okay, brilliant, thank you. All right, so I'm going to put my timer on because I do have a habit of over talking, so hopefully I won't go too long. So thank you for joining and listening. My name is Chris Kyriakou and I'm a counselling psychologist at the Royal Brompton, and I basically treat people with all different types of lung conditions. Thank you, Rachel, for acknowledging really the psychological impact that having a lung condition has on these patients at the best of times. So I just want to share with you about what we've been doing within the pulmonary rehab world, so delivering psychological support in pulmonary rehab, just really helping patients to live their best COVID life. So the points that I will hope to cover today is just looking again at the importance of psychology in pulmonary rehab and generally. Pre-COVID times, what that looked like and how we've had to adjust to meet the needs of our patients. The positives, negatives or challenges, as you would like to put it, and really what the future might hold. So this is just kind of to emphasise the prevalence of mental health generally and as well in our population. So 1 in 4 people in the UK will experience a mental health problem at some point in their life. That's quite high. We know that 30% of the UK population experience 1 or more long-term health condition at some stage in their lifespan, of which 4 million at the moment plus actually are experiencing a mental health condition. We know that the more comorbidities that we have, the more severe our mental health is experienced. And that people with long-term health conditions report having a sense of lower well-being. So there's always a bit of a circle that goes on here. So our physical health affects our mental well-being, and our mental well-being then affects our physical health. I guess more in respect of how we feel that we can cope with our health and whether we're engaging in our treatment regimes and things like that. So the value of psychological input is that it's really to tackle some of the issues that are coming up so that those with mental health conditions and physical health, we know that people have worse health outcomes. They have things like higher rates of exacerbations, more hospitalizations, readmissions, and having longer stays in hospital. We know that if you have a mental health condition and you're from a poor socioeconomic background, plus having a long-term health condition, you're much more likely maybe to have unhealthy coping behaviours, maybe drinking, smoking more, which has again a negative impact on your physical health. So having psychology available in pulmonary rehab is a great way where we can reach out not just to the patients, but we can also invite their carers to come along or loved ones, person of support, and they can really listen to the patients' stories and what's happening for them so that they can then better support their loved one. It's also a way that we can destigmatise and normalise what actually happens for us psychologically when we are having to manage or live with a respiratory condition. We know that now COVID's hit us, particularly at the beginning where things were kind of just shut down, people perhaps stopped exercising, even the motivated ones, out of fear of going out in case they became unwell. There was an increase of isolation, low mood, anxiety, loss of confidence, and it kind of just continued. So I think some of the concerns was, well, what is the impact this is now having on their physical health, and are they looking after themselves in the best way that they can? This is just reiterating the biopsychosocial model for you. So not to get too psychology on you, but it's just this idea that really with our physical ill health, we attend more treatments, we have to go to more hospitals, and psychologically we might develop negative thoughts about ourselves. I'm a burden, I'm useless, and point going out, and so we socially start to withdraw as well. So this is just kind of understanding what our patients might have been going through, or the general kind of things that come up for these patients before COVID, including panic and breathlessness, worry about finances, about whether they'll be able to continue working, and how they're struggling to kind of keep up with things. So this isn't to say this is for every patient. Some people adapt really well and they can cope and keep adjusting, and other people, what we might see is life's challenge, for them it's a really difficult time. So during my talks with patients, during our pulmonary rehab and outside of pulmonary rehab in my sessions, what I've noticed are these kind of common thoughts that people are experiencing, and they express things like the future being really uncertain. With Christmas around the corner, am I going to be able to see my loved ones? It's been so long already, and they're all getting a bit fatigued. For some people, it's been an interesting positive experience where they've said, finally, people get it. They understand that I have to shield and that this isn't something I'm making up. I've got a letter that justifies that I'm unwell. Some people are feeling very frustrated. Other people have said that they're in a bit of a dichotomy. You know, on one hand, when I'm at home, I know I'm safe, but I can't engage in any of the things I used to do or like doing, or nothing meaningful for me. And I'm really bored, and they're feeling really low. And equally, this idea of going outside, it seems really fun, but then there's the fear and panic of, well, what if I get COVID? And some people have responded very differently. Some people might take the risk and get in their car and drive around, or wave, at distance to family. And other people have just kind of stayed in and I suppose getting cabin fever. So common feelings. So these are the very common feelings people were feeling anyway beforehand. But I would say the difference with COVID is this has been a lot more heightened for people. So if they were feeling low before, this is a lot more severe. Anxiety, panic, the worry. And there are new worries that have come with COVID for patients. So some patients were holding down a job, and now they can't. And they're worried about what that might look like for them. There's different worries about is my hospital going to forget about me? Is it safe to come in and have that blood test done? I know I really need it, but what if my food delivery is covered with COVID? So there's lots of different types of anxieties. Although the feelings are still there, they might just be attached to different situations now, and they're a lot more intense. Pre-COVID-19, so how did we deliver psychoeducational talks and support? So our fabulous exercise practitioners and physios actually give out the PHQ and GAD scores, so your anxiety and low mood scores, and assessing our patients beforehand. And this was a really good opportunity to refer patients in-house or locally, depending on what they were presenting with. We would give 1-hour psychoeducational talks on anxiety and breathlessness, sleep hygiene, and stress management. As part of this, we also made sure that we gave plenty of time for group talks, and this really helps with peer support, again, destigmatizing things that, situations like, gosh, I'm feeling really embarrassed about my oxygen tank, but someone else does as well. And people kind of generally said that they feel that they get the best ideas from listening to other people and feeling encouraged to continue and building their confidence outside of the groups. The I suppose drawbacks to what we had before was that if a psychologist wasn't around, then that talk couldn't happen. We'd have to reshuffle it somewhere else. There was also, I suppose, the aspect of if people were too unwell to travel, if it's too far, if they were unwell for the day, they would miss out on that talk, and there was nothing else to kind of give them so they could kind of go back. And it also wasn't standardized across our trust, so between our site and our Harefield site. So some of our patients might be, as well as myself, thinking, I thought life was rough before, and then COVID happened. And hopefully, though, you're feeling the same way as me, which is some of life's best lessons are learnt at the worst times. So myself and my colleague got together, so Sophie over at Harefield, and thought this is a really good opportunity now to think about how can we revamp our talks and our information to make it meaningful for patients, and maybe not just our pulmonary rehab patients, maybe all of our respiratory patients, because we notice that they do share similar issues maybe. So we thought, let's go back to the drawing board here, and even if the topics are similar or the same, could we involve more information? Could we make it more holistic and develop them so that they've got more of the new psychological approaches to the talks. So this is also a way that we could standardize what we're offering to patients and thinking about how we can change our delivery and approach. So what we did is we actually created 5 pulmonary rehab videos, and I'll talk to you about 4 of them, but the pros so far of creating these videos is that you can play them in the absence of a psychologist, so you don't always need us there, so that gives a bit more flexibility. There's also flexibility of each individual kind of site really and how you want to use them. So at Harefield, they're giving patients leaflets first, then they're having some group discussions in the actual pulmonary rehab talking part, the group discussion, and then they are giving patients these videos after, so kind of as a complementary or kind of information and just giving them an add-on. Whereas at my site, what we're doing is we're kind of playing these videos. We've actually got more time, I should really say, as part of our pulmonary rehab session. So we are playing these videos in the sessions, and then we're having some group discussion. And again, these patients do get these videos afterwards. So this allows the patient to replay and go back to information and share it also with friends and family or whoever it is they want to share with, so they can also understand what they may be experiencing. We've made transcripts, and this was because we're thinking about the hard of hearing, and we were thinking about people who don't have access to the internet or just aren't confident using it. So in the I suppose negatives then, so challenges that we're having. So I guess like any of this kind of video conferencing, it depends on someone's internet access, any issues with their signals on the day. People are feeling a bit videoed out, so maybe some video fatigue going on. When we're talking about group discussions, we can only really facilitate it for smaller participants, so maybe 4 or 5, whereas before we'd be able to have a group discussion of up to, I'd say, 12 quite comfortably. There's also potentially the issue of confidentiality. So although, people have all agreed to sign up to this, we don't know who's in the background. And so as people are coming forward and sharing their experiences, we don't know who else is really listening. So that's potentially something we need to look out for. Time management also, so it's perhaps sometimes a bit easier when you're seeing people face to face to read the room and to kind of direct the conversation more easily. So that kind of then brings me to a study that was quite interesting. So Harefield did a study, and what they had found was they gave a survey out, to 170 pulmonary rehab patients, and they asked them about whether they had access to the internet, devices that they have where they could get onto the internet, and how confident they were at using the devices. And interestingly, 10% did not have access to the internet. 31% had a digital device but never had actually used the internet before from that. And less than half expressed that they were extremely confident or quite confident at using the internet. So that brings me kind of back to how ready are our patients to receive psychoeducation in pulmonary rehab in this format. And I attended a Action for Pulmonary Fibrosis meeting yesterday, and they kind of have a very similar approach by using videos to support patients. And what they've suggested, or what they've been doing, is having educational sessions about supporting their service users to use the internet. And that kind of got me thinking about, well, what's the steps and how do we get our patients to be able to use this, and is this something we need to look at or do more of if we're going to keep this way moving forward. So this is just a quick overview of 4 of the 5 talks that we're doing. So the 5th one was around, I think I already said, about helping patients to feel more contained during hospital admissions and about treatment burnout. So living well with a lung condition. And so again, we've just developed it a lot more and it's a lot more detailed, to the point we've actually ended up having it over 2 videos. They just address things slightly differently. So just teaching patients that they don't, one box doesn't fit all. You can try in different ways to manage your mental health, identifying your stress and stress management, and sleep and relaxation. So I kind of talked a bit about how we've adapted and incorporated more psychological approaches. So this was just how we used to do it, really. It was much more of a cognitive behavioural therapy approach. So thinking and teaching our patients about how we think affects how we feel, our physical responses and our behaviours. And I think more importantly, during COVID, what's really come up is people are very much anxious about the future and maybe feeling a bit low about the past. So mindfulness has become more and more of something that we've seen, I think, with everybody actually nationally. So this is just a nice little picture. So we're teaching our patients a lot more on how to use mindfulness in our everyday during COVID. And about compassion. So this is another way, or another kind of psychological approach that we've also adapted. So we've heard a lot about people feeling useless, being a burden, particularly having to rely on somebody to go out and do their shopping for them, or now collect their medication, and all those types of feelings and thoughts that they've kind of conjured up and have about themselves and their situation. So teaching patients to be compassionate to themselves is something that's really helpful in different ways, and they can do that. And the other psychological approach we've also now incorporated is something called acceptance and commitment therapy. It does have elements of mindfulness in there. It talks about not getting hijacked by your thoughts. So, you're not your thoughts. It's just, it's there, they exist, but that's not who you are. And then I think more importantly, and the thing that's come out more and more, is your value. So helping patients to understand what is really important to them. How do they want their time in COVID to look like? How can they make every day that they live meaningful, purposeful, and having a sense of joy? So I guess the take-home message for them is just a bit like this slide, really. Life's like a camera. Focus on what's important and capture the good times. Develop from the negatives, and if it doesn't turn out, take another shot. So what does our future look like? So we would like our videos to be accessible online. So at the moment, we're having to email them out to our patients, and the dream would be that patients can go onto our website and play them as and when they need to. So it's always available and accessible to them. That we can create not just leaflets that are downloadable, but also work booklets. So kind of building on from what we've already done. We do need to get some patient feedback, so that's our next stage, really. That should be number one, because we haven't done that so far. We've just kind of been in the thick of it, getting them made and kind of delivering them. And as part of it being on the web resources, we are hoping that we could get other healthcare professionals to use them, so signposting their patients that may not be part of the pulmonary rehabilitation programme yet, or people that have already come and gone and need to revisit some of the themes or topics that we've talked about. And we can use it for our inpatients also, so who are struggling, so they can go back and maybe do stress management, for example, or sleep hygiene. And again, just building, can do more meditation exercises, guided imagery. So there's a lot more room for this. The other thing is we can use it as a stepped care model. So perhaps we can give our patients these videos first, and the work booklets, measure their kind of low mood and anxiety before and after. And if they are still struggling and there's issues that are still remaining for them, then, we can give patients a referral to our in-house psychology service for kind of one-to-one therapy. We may also kind of move into doing a psychological assessment for our patients before they even enter pulmonary rehab and after. So we can use that through Microsoft Teams, and the information will get kind of automatically transposed onto Excel. So we can look for risk very quickly, and we can just kind of, it will calculate all the scores. So we can get a very good understanding of the patient's needs as they come in throughout and at the end of their time with us. So that is it from me. I hope I'm just a bit under time, but thank you. Any questions?
Thank you so much. We have got lots of comments, and thank you for being bang on time. We've got lots of comments just about how amazing this is, and it's such a shame that it probably can't just be picked up by lots of other organisations and used. That's one of the most common comments. If you can just give them it.
Well, they might. Sorry, I was going to say a comment to that one is, so we know that the North Tyne and can't ever pronounce them. There is a trust actually that have, I suppose, developed their own leaflets and got their own stamp on there. So there's nothing to say that we can't do that and share that with the rest of the hospitals that are out there. So I think, why rehash the wheel when we can share good work?
Absolutely. Now, Vicky asked what platform you're using for your recording.
So just PowerPoint presentation. So I'm definitely not a techie person at all. I was freaking out 5 minutes before today's talk even. I was like, couldn't get on. So through PowerPoint presentation, you just need to make sure you've got the right or the up-to-date version of it. Otherwise, you'll do what you think is wonderful recording and it will wipe it off for you. So you can do that and then just talk to your comms department and they will be able to make that accessible on your website, and they'll be able to convert your leaflets into digitalized versions of it.
Thank you. Now, we have a comment from Adam Lewis. I'm going to read it out, but not read it all out. Because he's basically saying hiya. Great work on the PR videos. Have you compared COVID era GAD PHQ outcome measure changes versus PR service pre-COVID average changes?
No, we haven't. So that would be a really good point to do, actually. So I think that's something that we can look back on. So I think our exercise practitioners got all those scores. So that is something we need to visit, I think, as an evaluation. So that would be the next stages. Yeah, so that's probably a bit rubbish on our part, but in my defense, we have been really busy. So yeah, no, that is the next stage for us. We need to evaluate the how good these videos are on their own independently. And I think comparing the level of low mood and anxiety pre and post pulmonary rehab generally, and pre and post COVID and now. So yeah, thank you. That's a good point. I will look into it.
Did actually use those words, nice little service evaluation there, slash digital habits paper.
Yeah.
And obviously, if you have any spare time, Adam, and you'd like to support in that development, you're more than welcome to virtually pop into the Brompton and we'll organise that.
Absolutely. And I think if we can develop, so we've now discovered that through Teams, we can send off digital kind of questionnaires actually to patients, and it comes back in real time, and then the information then can be auto-populated onto Excel with a great way that they can flag up if somebody's ticked the suicide box. So that's something that we're in the middle of developing at the moment for generally psychology services, but how we can use this as part of pulmonary rehab too. And if I'm thinking about either, that it's endless, and this will really help us to identify the prevalence of mental health amongst our patients, and help us direct and triage them, and it would be great for auditing too.
Yeah, and I mean, we cannot stress, can we, the impact that COVID-19 has had on this population of patients, also our respiratory patients not being able to access the normal support mechanisms they would. So any kind of asking the question, then when you ask the question, if someone discloses or declares, what then can you offer? And I think what I've learned from psychologists over the years is it's okay to ask those leading questions, but you have to have the skills or the signposting to be able to know what to do if people do.
Absolutely. Thank you, Rachel. That's a really important point. So if somebody is expressing suicidal thoughts, then it's kind of just knowing that, you know, where to signpost them to, obviously GP or A&E. But I think having some resources for patients that they can access any time is really important, and not, you know, because the waiting lists are growing to see psychologists. Or I've had patients that have said to me they are shielding themselves. They lost 2 parents within the space of 2 weeks from COVID, and couldn't get access to psychological support until they kind of, I think, cried in a consultation. It was flagged up to me, but you know, that's just an example. They couldn't get any support outside of the trust.
And this probably highlights even more the gap. So some services have really good access to psychological therapies, iPad services, and a lot of services don't, and rely heavily on crisis teams for intervention, etc. So I know there's lots of support out there now. There's lots of support around the very acute end, so in terms of critical care admission and getting psychological support very much in the acute environment, but we cannot forget the other end of the pathway. So I know a lot of patients that are now needing support are the patients that never came through the hospital front doors, and there's now a complete discrepancy, and we're seeing this with long COVID. The long COVIDers who haven't had the hospital admission feeling probably are completely neglected by the system because they haven't had that like acute admission to default back into. So yes, there was just a comment from Fiona about the musical health, the musical breath signpost, and so there's an email she's put on YouTube, and she is doing the session next. So I'm not going to talk too much about that, but I just want a final thought from you about the service you provide to respiratory patients has never been more important than now. What advice do you have for people who are listening to this who don't have an access to you, who don't have anything? You know, where do people even start to collect any evidence in this time to really start to demonstrate the impact of having you in their service?
So I guess that's building, isn't it? Building a case for having mycology. So I think if you can, I would advise you guys to, you know, firstly you can contact me and I'm happy to kind of help where I can, but definitely start to record your patients' PHQ and GAD scores if you can. They are free. They're free psychometric scoring, and it's very easy to score. So that will give you an understanding of the level of severity of mental health, but also just then to just make sure that you do check it on time, you know, in a timely manner. So if anyone's kind of ticking that suicidal box, you can ask them to see their GP immediately or go to A&E. And as you're building that, you can understand what's happening for your patients, getting your demographics in as well. So who's struggling more, what are their conditions as well. And then I think just kind of asking them, you know, is this something you do want? So some patients, interestingly, kind of might refuse it, but sometimes they're the ones that are having the hardest time to accept the help. That they really do struggle. Maybe that's their way of thinking about things. But it would also be useful, I suppose, to see if there are any other issues that they've got. So if they've scored high on depression scores, do they have a mental health condition already, a pre-existing one? Are they on any antidepressants? And also, what's going on with their health? Are they presenting because they're not, you know, poor adherence? Do they understand what's going on? There's something called the PAM tool as well, although that does need a license. You may have heard of that already, a patient activation kind of engagement, seeing how much people are motivated to engage. So just get as much information as you can, get some objective data, looking at how engaged they are at looking after themselves. Are they coming into hospital a lot more? And then you can kind of present that, because there is a very, very strong link between your ability to look after your physical health and your mental well-being, and they kind of impact on each other. Okay.
And what a wonderful note to finish on. Well, thank you so much for your time today. You've been amazing. Lots of comments coming through, and just everyone found that a really informative session. So Thank you, Chris, very much indeed, and enjoy the rest of your Saturday.
You too.
So we will take a short 15-minute break. Please come back at past, and we will be ready to see you all back for the final session. So see you